Okay, good morning, everyone. My name is Leah Henriksen. I am the program coordinator here at KC Digital Drive, filling in for Leslie. Um, Thank you so much for joining us for today's KC Coalition for Digital Inclusion. We have these monthly meetings every first and third Friday of the month. Now, go ahead and get started on my slides here. I'd love to point out at the beginning of our meetings our mission and vision for this coalition. The vision: every citizen and household in the Kansas City metropolitan area has access to the internet, equipment needed to use it, and skills needed to take advantage. The mission is to facilitate collaboration amongst organizations and initiatives working to bridge the digital divide to maximize the resources for the greatest impact. I also like to point out, as we're thinking about our different partners that will be presenting, Kansas City as the metropolitan area has both urban and rural parts of the city. So we're always thinking about, who has the greatest need, where are these resources able to best impact the most underserved folks of the area. If you'd like to follow us on any of the social media platforms, these are all of the handles, and you feel free to follow the YouTube channel to see the recordings after this, and the website, digitalinclusionkc.org. So I'd love to take a second to give space for anybody who is new. This is your very first time on a KC Coalition for Digital Inclusion call. Please fill out the interest form if you'd like to join as a coalition member. It's free. And I'd like to create space now to see if anyone is new to this call. If you'd like to unmute and or put in the chat and a little intro for yourself.
Well, I'm new. Good morning, Raquel Garcia. I am a 21-year nurse in community health realm, and I am new to AI digital everything. So I'm a newbie, but I am so excited to be a part of the coalition and to start learning from all of you all. So thanks for having us, and I'll be presenting here in a little bit and dive a little deeper into that.
Thanks for being here, Raquel. Are there any other new folks on the call?
Good morning. I'm Emily Ng and I work with Raquel. So I've been in the community health world too. And I would say with our past positions, we didn't really focus on digital inclusion. So this is kind of new for both of us. And I'm excited to be here.
Thanks for joining us, Emily. I know there's at least one more new person. I don't know, Kevin, you want to introduce yourself? I know you'll be saying hi in a little bit.
Yeah. Hi everyone, I'm Kevin Lopez. I'm new here and new at the CBB. I've been here for 2 weeks now, and I'm going to be the new digital navigator. I'm helping set that up. Thank you.
And you'll hear more from us here in a little bit. I'm Gustavo. I was on the meeting last week, but this is both of our first time joining this meeting, so thanks for having us. Looking forward to sharing more about what we do and learning more about what you guys all do.
That's
I'm not
great.
100% sure, but I think Carly and Ashton, this may be their first time.
I believe Ashton's been on before.
I was on one additional time before, but Carly is my coworker, and I forwarded her the invitation. She's actually working on a grant that's helping to get cell phones and data coverage to the patients. And so I was hoping that you guys would be able to maybe provide some feedback or connect us with somebody that could help, because this is a brand new program for us and we've never really done anything like this before. So Carly probably has more details than I have, but I sent her the invitation so that she could hopefully get connected with some people with answers for us.
Awesome. Thank you.
Yeah. Hi.
And if you guys want to post your email addresses, in the chat, we can make sure that you get looped in and we can help facilitate follow-ups.
Yeah. And yeah, I'm Carly. I'm the social worker here at the clinic. I work on a bunch of different grants at our clinic, but we just got one from KDHE that's going to allow us to provide like hygiene items and other like care items for patients, and alongside that, we were able to include like cell phones and cell phone like data plans. We haven't started the grant yet. This is in the very early stages, but we're hoping to purchase phones and data plans to give to patients who don't have access to telephones or cell phones so they can complete telehealth phone calls and connect with services, connect with other community services that are available outside of the health system. And then we have another grant that we're kind of mushing together with the KDHE grant from KFA, and it's for us to be able to provide telehealth services from our addictions clinic to rural communities out in Kansas. So that goes hand in hand with the cell phones. If there are patients out in the rural communities that don't have access to telehealth, we would be able to ideally give them a phone to complete those calls. So Ashton mentioned this to me this morning, and I was like, let's see what they have to say and what they're presenting on. I was like, that kind of works out perfect. So I'm excited to be here.
Um, Carly, this is John Fitzpatrick. I was just wondering if any of the money that is flowing in that direction right now is coming from the Rural Health Transformation Project yet, or is this from other sources?
The So one of them is from KDHE, that's for the supplies. The rural telehealth grant is from KFA, Kansas Fights Addiction.
Okay,
Yeah.
okay, thank you.
Carly, I think you and Ashton came exactly to the perfect meeting. And we look forward to collaborating, kind of hearing what everyone has to say and going from there. Let's keep this work going and supporting each other. It's awesome. All right, I'm going to keep us going. We have a few more slides here. So thank you everyone for sharing and speaking up about new members. Today, our featured content is going to be John Fitzpatrick on our team. He is sort of the health digital innovation expert on our team for KC Digital Drive. And then we will hear from our member updates from the Heartland Wellness Connection, formerly Welcome Wellness with Jeannie Midget. We're going to hear from Raquel and Emily about how their brand new program is doing. And then we will also hear from Gustavo and Kevin from Care Beyond the Boulevard. So I would like to kick it off and turn it over to John to start his presentation.
Thank you, Leah. Let me just get going here. Okay. Good morning, everyone. I'm John Fitzpatrick. I'm the community health strategist for KC Digital Drive, and I'll be throwing in a few bits of my background as we go along this morning. So there's really not a need for too much of an introduction. I've been working alongside KC Digital Drive for about 12 years, and for the past 3 as a full-time person on the team. I'd like to talk today about the promise of a digital life, particularly in the context of health. One of the references that we often use around here is the connected health community. And I'll discuss that as we go along today, and also raise some of the projects that we've done in alignment with this over time. I want to start off by being very clear about the challenges. We're really wanting to talk about the promise of these technologies and approaches, because it's not just technology, it has a lot to do with strategy and approach. But there's no denying that there are challenges, just as there are anywhere else in the digital environment, around availability, affordability, privacy and safety, and so on. And understanding that, for instance, if an organization is going to be adopting new technologies, that they have their own staff capacity issues to deal with as well. So we're not denying or avoiding those things. It's just that we want to look at this kind of from a straightforward opportunity perspective. I wasn't quite sure how big our group would be here today, so I did want to just say a little bit about KC Digital Drive as an organization. We are a nonprofit here in the Kansas City area. Um, our mission is to make Kansas City a digital leader and to secure economic prosperity for all in the region. We have a bit of an origin story. You don't necessarily have to read all this. It really boils down to the fact that we were founded when Google Fiber came to town. The mayors of Kansas City, Kansas and Kansas City, Missouri got together. They called together some senior players from around the community to think through how to make the best of this opportunity of Google Fiber arriving. How could it lead to economic development? How could it lead to innovation? Quite a range of things. And within that context, they put together a playbook from these senior leaders across a number of different domains that, so from our founding, we've been looking at handling things like civic tech and healthcare and even, especially in our early days, gigabit applications and so on. So it's quite a range that they laid out in the playbook. Aaron Deacon, our current general manager and founder, was part of that process, pressing on that team, and ultimately was selected to lead the charge as the playbook was published. Within the specific area of healthcare, where I am focused, the playbook set out a need to address telehealth and reimbursement. The reimbursement part is kind of a challenge specific to telehealth because a lot of the regulations associated with telehealth aren't just policy. It's not just the Department of Health and Human Services setting certain policies that they can change at will. There are many, many constraints that are written directly into law. And so during the COVID pandemic, a lot of these constraints had to be released by waivers within new laws that were written by Congress. And this is still traipsing along even today. At the end of this month, there is a continuing resolution that's up for reapproval, and that carries with it all those waivers of restrictions of telehealth that happened during the pandemic. So, for instance, telehealth prior to the pandemic, a rural hospital could not do telehealth to its patients. It could only do telehealth between their facility and another facility. There are a number of different things like that that were not being reimbursed by the government if a institution chose to operate in that fashion. So the reimbursement part has always been a challenge. We've been fortunate to see some changes, as I said, with these waivers, but a lot of us in this domain really need to keep working to make sure that a lot of those waivers become permanent. We sort of enhanced that charge as we went forward, speaking a little bit more about health rather than healthcare. Health really involves much more than just care. And telehealth, for one thing, is not just that video session you have with your provider. It's also anything else that is tele in health. So, for instance, the apps that you use that may connect to your patient record would be considered telehealth. Remote monitoring of your health condition would also be considered telehealth, and so on. And then we broadened the telehealth thought to really incorporate what we would call digital health. And likewise, digital health is all things digital in health. And so that means electronic health records, wearables, imaging, whatever really you can think of that has a digital element falls into this category. And then we've kind of relied on trying to come up and work with partners on use cases in these categories that show benefit that could change reimbursement. So it's not like we've completely forgotten that. We have that in mind when we think of projects being somewhat of a demonstration of the value such that they could be eligible at some point in time for reimbursement, and therefore much more easy for providers to extend to the community. One of the things I guess that I find foundational, and I stole this slide from a 1994 presentation from Cerner Corporation, where I used to work. So this is over 30 years old, and it was trying to take the understanding that the person really is the unifying principle in the community, and that in that extent, we take that in a health environment, we take that person through a process. And that process is really straightforward. And one of the unique things about this, I think, and important things to recall, is this doesn't apply just to the clinical engagement of a patient, but even the person in the community would be going through this same process if they went for social care at a social care provider in the community. Another bit about this is that there was this understanding again, a slide I stole from Cerner from 1994, this understanding that there was now this ability with the internet. So even 30 years ago, there was this understanding that with the internet, you could connect in many ways to all kinds of venues of care across the community. It could be outlying clinics, it could be a telecare engagement with sort of a call center, it could be home health workers doing their documentation and uploading that to the internet, and extend fully to the home. And so you have this very old photograph or very old image here of essentially a dial-up sort of idea, but still the idea that the person could be connected as part of the overall scheme in managing their health. And it got very sophisticated. I won't go into this, but it was an understanding that with connectivity, with process, you were generating data. And with data, you had a lot of power. You could use it for improving processes, for improving outcomes, and so on. So that reach across the community became tremendously powerful. One of the things that I liked about the playbook is that it spoke about telehealth rather than telemedicine. Telemedicine kind of got defined as being a one-to-one encounter with a person between a provider and a patient. And it typically involved very sophisticated and expensive equipment. And we just learned over the years that so much of that was not necessary, and that a lot of stuff didn't even really require the one-to-one relationship that, for instance, as you know already, many of your health apps, a variety of people could be using those and uploading their data, and the health system can be judging that data as to whether or not any intervention is required. And so it's a one-to-many relationship rather than just a one-to-one relationship. I was involved in a case where I was consulting with the World Bank. The World Bank wanted to provide healthcare into the occupied territories in the Middle East, where people were not allowed to come in or leave. And they were thinking in these terms, this kind of heavy-duty equipment, one-to-one relationship, and so on. And the group that I was working with, really convinced them to look at more of a data equation of having more information about the people they were working with and that data could be fed to them, not just one-to-one, but what we would call asynchronously, and it would allow them to manage many more patients than this previous telemedicine paradigm. So what we kind of arrived at was an idea that within what we call our health innovation team, we wanted, first of all, to make sure that digital health was broadly spread through the community. And one of the ways that we were doing that was through community building. And so since the time of the founding of KC Digital Drive, we've held a meeting nearly monthly over those more than 13 years now to discuss digital health topics. And that's still ongoing. And we do that within the context that I'm expressing here, which is that life is a continuum, and that involves events, venues, the obstacles that you run into, the advances, and so on. And that it really is overall about well-being. It isn't just about care in a specific instance. It's not just about going to the urgent care location. It includes that, but it's so much more than that, dealing with wellness and your social needs and so on. And as I showed in the previous slide, the kind of pared down version of the community, it can all be connected by process, data, knowledge, impact, and so on. So how do we go about doing that? We think in those broader terms that I mentioned of digital health. And so we want to do that by being strategic. We can't cover everything. We want to cover those things that give the greatest positive return for the person and the community. And we also want to make sure that it's appropriate to the person and the community. And a lot of that has to do with working to help make sure services are aligned and harmonized and delivering what they're supposed to deliver. In a broader sense, that the health innovation team, as I mentioned, brings together these disparate partners for discussion. And we look at enlightenment and potential action that may happen in the community. We look especially at the social drivers of health and the health of populations, particularly rural is growing up as being very important in our area, and maternal. And I'll come back to that in a second. But it really comes with the understanding that it's not just a case of if you build it, they will come. With technology, you really have to go to where people are and build a level of trust for people to be able to adopt it. And so what we say we're trying to do is go to where people are and finding what we would call the connectable moment. What's the right time, place, context for someone engaging and starting to manage their health through these tools that are available to them. There's kind of a misconception, though, with digital health because of just how quickly things go viral in the digital world these days. And there's so much focus on genomics and our genetic background that we kind of start to believe that that's everything we need to know about our health. We also think that we can, as we sort of implied earlier, is you can literally connect to anything anymore. But what does that lead to? A lot of people kind of come to the idea of what used to be called the quantified self, that they could have like a Star Trek tricorder to be able to cure everything in front of them. And that's really that idea of just adding those things together and getting what you need is really not enough. We need to start looking again of where the people are, what their circumstances, what their context is. Understand that the person remains the unifying principle, not only in that clinical process, but the process for finding additional services for them, both wellness and sickness and social care, really goes through the same process of identifying the person, assessing their need, determining what resources are necessary to address that need, putting together a plan, enacting that plan, evaluating it, and referring on to further needs. And one of the things that we have done as a project in terms of this, going to the people and understanding the person remains the unifying principle, is that we've worked with community health workers across the metro area, which involves the 9 counties that the Mid-America Regional Council covers. We've worked across the metro area with community health workers, first of all, to help them build their own digital skills so that they can do things like document in the case management system that their organization uses, or in the electronic health record that their organization uses, and then build out more digital comfort and digital skills to be able to convey those to the people that they serve. So I was really pleased to see Kevin introduced today as a digital navigator specific to health. That is exactly the direction that we've been going with community health workers, is to help make them the digital navigators that can go to where the people are, help build the trust level and the skills to be able to participate in managing their own health. What's interesting, and why in this slide, I put all of these factors and entities on the left-hand part of the slide, is that it's been determined, and this really comes from the federal government, it's been determined that about 80% of your well-being is not clinical care. That the traditional healthcare and genetics only make up about 20% of your health status. Everything else is based on your behaviors, your physical environment, and socioeconomic factors. And I know that this coalition has a lot of agencies that are involved across these kinds of services. And that really is what you may have heard referred to as social determinants of health. The preferred term really these days is social drivers of health. And the federal government actually prefers health-related social needs. But it's all the same thing. It's that 80% that isn't genetic or clinically delivered. You may have run into, in any one of your own visits, an assessment being given about, for instance, this is an example, in the last 12 months, did you ever eat less than you felt you should because there wasn't enough money for food? So there's questions about food and transportation and whether you feel safe at home and those kinds of things. So that assessment is literally the social drivers of health assessment. And based on that assessment, the provider helps to put together a plan of care that involves social care as much as it does medical care. There's actually an effort to really define all of this. It's called the Gravity Project, and it's national. It's got hundreds of people involved with it, and they have determined that there are at least 22 domains in the area of social drivers of health. What's interesting is that they have not forgotten, as you'll see here toward the bottom, digital literacy or digital access. That in fact, these become super drivers of health. And this is the link to be able to drill down. And under digital literacy, for instance, they're thinking about inadequate skills, those affecting healthcare, plain language, translation service needed, those kinds of things. So they're thinking about all the factors around digital literacy as being fundamental for people to be able to manage their own health. Just a second here. So these are those domains, and it includes, for instance, intimate partner violence. We'll come to that in a second. That is actually a significant cause of maternal death in the postpartum period. So that all of these things have really fundamental importance. One of the things that people have found in studies is that a lot of the concentration of these of the negative sides of these social drivers are often geographically bound, basically poor neighborhoods. And so there's this thought that, and people have discussed this before, that your zip code is actually more important than your genetic code, because as we said, genetic code is less than 20%, whereas the social drivers are 80. So in that respect, you could say geography could be destiny. One study done here in Kansas City by the Robert Wood Johnson Foundation found that down here at the lower center, that the Blue Hills neighborhood has a life expectancy of 69 years, and the Armour Hills neighborhood has a life expectancy of 83 years. There's a 14-year difference in life expectancy between two zip codes where you can literally walk between them. It's less than 3 miles distance between those two neighborhoods. And yet there's a 14-year difference in life expectancy. So a lot of what we try to do is find ways that we can help technology enable people in underserved areas to be able to manage their own care, bring up their standard to a level that it really counts in terms of well-being. There are systems that help with those social drivers. Iris that I'm showing here is one of them. It happened to be developed here in the metro area. And what happens with the IRIS system is that if you're a community-based organization offering services to the community, in the first instance, a community member would access the community-based organization. Again, we'd go through the same process for social needs as we would for medical needs. We assess the situation, we find the resources and put together a plan for addressing, for engaging those resources. And this system is electronic and allows those referrals to be sent out to agencies that can help serve those needs. And the agency can either accept it or reject it. In the acceptance case, it's kind of a two-step process where they notify the community-based organization that they have accepted it. And then they also notify the community-based organization when they've completed the work, or what we would call the disposition of the work was. In a rejection, it's one step, but people are then encouraged through the electronic system to give a reason for that. That their organization was beyond their capacity, or they were closed for the holidays, or those kinds of things, to let people know why they couldn't deliver that service. And all that can be tracked, just as your health record is tracked. And so these issues around interoperability and that sort of thing become really vital for digital health. And I kind of want to close on another project that we've done. In terms of going to the people, we mentioned work with community health workers. We've also done projects to help people understand how to use their patient portal and connect to it and be able to see their own patient data at their providers or on their provider system and so on. But a probably more esoteric thought that we're working on right now is understanding that maternal health is also its own continuum, and that goes from pre-conception through prenatal, through labor and delivery, and on to postpartum, which best practices say a mother should be tracked for at least 1 year postpartum, because in fact, that's where most maternal deaths happen. And so one of the projects that we're working on right now, as Casey Digital Drive involves several partners. It involves cooperation with the mother and child health departments in the states and the region and so on, to think through what that continuum needs in terms of data to move it along effectively. You'd be surprised at the number of places that are still faxing their data between one another. So it's not consistent, it's often not available, and so on. And so we're working with some support from the federal government to be able to define what those processes are and the data associated with them so that we can drive better outcomes within maternal health. The United States, as you might be aware, is woefully behind other countries in this respect. We have twice the maternal deaths that countries like Canada and the UK have. And also, even more particular to that is that, for instance, the mortality rate for African American women is more than 3 times that of white women just in the United States. So there is a lot to be done to iron out that continuum. It has so many handoffs from gynecologists to family medicine, to labor and delivery, to all the services that someone needs along the way, for like Lamaze and those kinds of things that all need to be worked in, scheduled, supported, and ultimately reported upon, so are you getting the outcomes that you really see? So that's kind of one of our big projects right now, is to see if we can push this idea of normalizing maternal health data across at least the region, but ultimately hoping that it's something that gets picked up at a national level. So that's kind of our big project right now, continuing with the community health worker work that we've done and others as well. So I'll leave it at that, and I'd be happy to answer any questions that you might have.
Thank you so much for presenting, John. That was very in-depth. I really appreciate all the images, and specifically, I think the map of the metro area and just how important the zip code that you have. That's pretty real. That's pretty honest.
Yes.
Does anyone have any questions? It looks like Ike has a question.
Dan, can you go back to the first slide?
Oh, sorry. I just shut it down. Yes,
That's
just a second, please.
That's okay.
Somehow I'm getting stuck.
And if anyone has any questions in the meantime, feel free to drop it in the chat or raise your hand.
Which one did you mean?
The first slide. Let's see.
This promise of a digital life.
Number 7.
7, okay. Yes, sir. I missed it. Yeah, there we go. Tell me how I can help.
That's it. I just needed the information off here.
Okay, oh yeah. Yeah, and as I mentioned, we really see this in our digital work as applying really across the board, that whether you're seeking medical services or social services, you really go through the same process. You should be collecting the same kind of data. We should be getting much more knowledge out of people's health and wellness journeys.
It might be good, John.
Thank you.
Would you like him to send you this image? Because he can definitely send it to you.
Yeah, I'm happy to
And
do so. I'm happy to do it, Ike, no problem. Any other thoughts?
I love how that is consistently a good resource for you, John, even being a little old.
Yeah. Yeah, it is. I mean, it's so simple, and it applies today just as much as it did in 1994. And so I use it all the time. But I encourage anybody on this call to contact me about anything that happens in digital health and where you might need support. I'm I've always been very interested, for instance, in Care Beyond the Boulevard and how your team is able to um, capture data and then refer people onward and so on. That continuity of care is just such a vital thing, and always interested to see how your group handles that. So let me know.
Yeah. John, do you want to drop your email, your contact info in the chat, just
I
so
will do.
folks have
Yeah.
that?
Yes,
All right. Great. Thank you so much for presenting, John.
my pleasure.
Let's go ahead and move into our member updates, and we'll start with Raquel and Emily with Heartland Wellness Connection.
Hi, guys, again. So, Emily and I are charged with introducing our new project. If you guys have been around long enough, you might have met Janine Majette. Janine Majette was the executive director of Welcome Wellness in the Cass County Belton area. And she wanted me to send my thanks to Lindsay and Rachel and John for always being supporters of Welcome Wellness over the years. Welcome Wellness was initially backed by Cerner and the Patterson Foundation for many years. And they've sunsetted their program completely as of December 31st. So Welcome Wellness is no longer in existence, and out of that grew our Heartland Wellness Connections. We heard the cries and screams of the community to not let this go completely in that county, and we partnered with Health Forward Foundation to continue a program of some sorts. We aren't going to fulfill everything that Welcome Wellness was doing in Belton. They were very program focused and class focused, fitness focused, and screening focused. And we are switching gears to being more of that digital access with our new initiatives. So hello, and I hope that you guys all welcome us with open arms. Again, Emily and I are new to not only the digital part of learning with health and wellness, but Cass County in general. We have, not to toot our own horn, but we have mastered the Jackson County area with working for University Health. I had worked for University Health for 15 years and led the community health program there, and we were very successful in that realm. So we're hoping to bring a lot of what we learned from Jackson County and what had worked in Jackson County out to Cass County. In our first couple of months of working with Janine through Welcome Wellness, we've learned so much about Cass County and their needs. So we are lucky that we get to develop our programming from scratch. One program that I just want to touch on today with you all that's going to pertain to everything that John said in his presentation. It's not that I didn't have questions, John. It just felt like you were talking to just me. So I'll have so many things. Everything you're doing is amazing. I'm so glad that we have you as a supporter because everything you talked about is just so on point. And Cass County is going to need this. What I'm realizing is that, man, there's a huge gap out there in Cass County. So one program that Welcome Wellness did have was the Tech Tutors program. And if I can, Leah, just show a video really quick. I'm going to share my screen. This was a program that they initiated years ago with the Belton High School out there. Can you all see that?
Yes.
Okay, I'm going to play the video.
My favorite part was when I was on that laptop, the computer. I think it was a good experience for me. Para mí es nuevo usar una computadora porque es la primera vez que yo la abro y he aprendido cómo entrar en ella y buscar lo que necesito. The favorite part of my program was being with the student that I had because she was very patient with me. I had a lot of questions for her, and she never showed that, like I was kind of dumb or stupid or anything. She showed me everything that was in computer, in the computer, because it's totally different when I used to work with the computers.
I have a computer at home that I easily work on most of that stuff. But the new things like saving my passwords and doing a few other things, she helped me do those. And the main thing is learning more at my age about the computer and little things like that. It's very, very interesting. Keeps me going.
Pero es la primera vez que yo uso una computadora y me da gusto porque el estudiante que me enseñó, me enseñó todo muy bien y me gustó todo lo que él me enseñó. Learning to use a computer because I was really bad with it.
So what they did is they partnered with Belton High School, and Belton High School has a curriculum where they teach their students to be, they're trained in HIPAA, they serve as peer instructors and digital navigators, and they learn in school, and then they are sent out into the community to help the older adults with learning how to use computers. They were only focusing on older adults, but we realized that we're going to expand that beyond because there's people even my age, 21, who cannot use computers in every form. And so we have expanded it to all ages, but we are developing this program to include community health workers. As John was saying, it's such a need. So we are going to include the health part of it. So we are going to teach them how to access their portal, do their digital visits, and we also want to provide them with a space that they can come to in Belton to utilize for that if they don't have their own personal computer, which Tech Tutors does provide all of them a free computer with the partnership with Google. But some of them don't want to use the computer that's given. They want to use their phone or laptop that they already have. And so what we're doing is just providing that space and that high school student as well as a community health worker to be their navigator for the whole process. So we will be building that from scratch, and we will be implementing it this spring. But what that Tech Tutors program is it can be implemented anywhere. It doesn't have to be with Belton High School. You just seen the Guadalupe Center high school students were trained in the same program, and they went to teach the senior citizens at Guadalupe Center Community Center. Super successful. They had 18 people graduate from that program, and they are begging for it to come back and wanting to learn more about closing that digital divide. And so seeing the success that Welcome Wellness has had with that, we just want to expand on it to include the health portion of it. And again, obviously the goal is to be reimbursed in some way, shape, or form. But I agree with you, John, that trust is the biggest thing that we need to develop. And so we are wanting to go wherever they are. So we will not have a brick and mortar. We are going to be completely remote. Our goal is to send our community health workers and the high school students to where the people are, whether that be their home, whether it's a farm somewhere in Cass County, wherever it is that they need to be, we want to be able to travel to them. So that is just one of the programs we'll be working on, but that's going to be the most important one that we'll need your guys' support on for this first year. But if anyone has suggestions or possible partners for us to look into to get this off the ground, that would be really, really helpful. But we are super excited to be able to try and close that gap for Cass County. Sorry, Leah, I was probably shorter than what you expected.
No, it's great. It looks like Rachel has a question for you or
Yeah,
comment.
thank you, Raquel. So you said you had Jackson County pretty well covered. Are you still doing this in Jackson County? What does that look like? And um, is it with community health workers or high schoolers? How would somebody get connected to you?
So we will mainly focus on Cass County, but no, we will still implement Jackson County in there. It depends on the schools that are interested in having their students trained in this. Guadalupe Center was an easy target for us because I'm on their board, so they kind of can't say no. But other than that, we want to start with the Kansas City Public School District high schools as well in the future. But yes, Jackson County will definitely be in on that. But they will contact me directly. And because we're only, like I said, 2.5 weeks old, we're still working on our website and the email addresses for that. So I will be attending the meetings from here on out, Emily and I. So I will get all that contact info to you guys soon.
Thank you.
Mm-hmm.
Raquel, is there any like specific kinds of partners that you're looking for? Typically, folks who already serve older adults or involved in the schools, like what are you looking for from this group?
Yeah, so with this group, I have never worked with community health workers before. So knowing I'm going to be learning all about that as well, because University Health didn't really use community health workers. We did have patient navigators, but everything was internal. So groups that already work with community health workers that we can learn from as well. But also, like you said, groups of senior citizens who they believe that can profit from this, who would benefit from this. That would also be helpful. And also to go along with what John was presenting too, I had just learned that Cass County, that women's care, the fact that there is nowhere for them to go during their pregnancy in Cass County, scary. So I am also trying to partner with anyone in Cass County that's trying to tackle that right now. I am in talks with the Health Forward Foundation LAN committee because that's their big focus this year. And so I am trying to partner with anyone that finds that as scary as I do so that we can tackle that and get visits that can still happen in Cass County. There is nowhere for them to go. If they have to deliver their baby in Cass County, they have to go to Lee Summit. Research is closed, so now they're going all the way downtown to Truman to University Health. They go to St. Luke's, Lee Summit. So that's another partnership. If you guys have other people who are wanting to tackle that in Cass County, I would love to start that conversation with anyone that is interested in that.
Yeah, for sure. That is alarming. I appreciate you
It is
flagging
alarming.
that.
I didn't know that. And so, yeah, I was talking to my sister-in-law's the nurse practitioner who does all the Children's Mercy high-risk pregnancies. And she was telling me that all the Cass County patients that they have miss so many of their appointments because it's an hour drive. They can't get there weekly because if you're a high-risk pregnancy, you're supposed to be there weekly in the end. And they miss so many appointments. So if we can help close that divide by having a virtual appointment with them seeing someone in Cass County where it's a 15-minute drive versus an hour drive. There's so many possibilities. And so if anybody wants to help me tackle that, my background is labor and delivery, so that is a really important area for me.
Yeah, for sure. Thank you so much for sharing. Emily, did you have anything to add?
No, I don't. Thank you.
That is okay. That's great. This is a great sort of insight into, counties that are given a little less attention, I think, in the metro area, speaking personally. This is great. I know that
Mhm.
our team can for sure and would like to support you in kind of exploring other partnerships. And I'm sure John's wheels are turning already, just kind of thinking about how best to support you. So hopefully you are able to feel that love and support from the group as you begin your 16th day of
I
operations.
know.
So yeah, that's great. Does
Thank
anyone
you
else have
guys.
any just sort of thoughts or shout outs to Raquel before we turn it over to our next presenter?
Thanks for having us, guys.
Yeah. Thank you, Raquel and Emily, for joining us. All right, let's keep on moving forward. Gustavo and Kevin, you are up next with Care Beyond the Boulevard.
Thank you. So again, I am Gustavo. This is Kevin. We're with Care Beyond the Boulevard. We have a few slides to go through. We're going to do a brief overview of our work at Care Beyond the Boulevard, and then we'll really get into the meat, the real update as it pertains to digital literacy and what we're going to do to help bridge that divide for our patients. So Care Beyond the Boulevard is Kansas City's only street medicine team. So we are, our organization exists to provide free medical services to our city's homeless, uninsured, and underserved communities. We hold about 40 monthly clinics. This includes mobile clinics, stationary clinics, clinics on our big green bus. And so all of our services are 100% free. We don't require patients to have health insurance, an ID, a birth certificate, a proof of address. If anyone is in need of medical care, they are welcome at our clinics. So on top of medical services, we do offer social support services tailored towards the population that we serve. So we'll get into that here in a little bit. As a brief overview of kind of the main pillars of our work, we have 4 of them. The first one that we'll mention is the big green bus. So as you can see in this picture, that's a mobile medical unit. So the big green bus goes out every Tuesday and Wednesday night. It's pretty much a full-on mobile primary care clinic. It goes out onto the streets, into encampments, depending on the time of year. For example, right now, as it's cold, we do take it to the cold weather shelters. When the weather is warmer, that ends up being parks and places where other organizations are providing food, water, things like that, so as to not duplicate services and build trust with the patients and those sleeping on the street. Another big pillar in what we do is street outreach. So these are smaller, kind of targeted outreach clinics, typically 3 to 4 volunteers or staff members go out to known encampments, harder to reach places. A case manager is always on that team, and they work with other case managers within the city. They coordinate with us, letting us know, hey, there's someone at this encampment that needs medical care. Can you guys go out on your next outreach clinic? So that is every Tuesday and Thursday. Typically around like 9 a.m. is when they'll go out, and just depending on how many patients they encounter, they'll be back within like around 3 or 4 p.m. Then we have the Care House. The Care House is our medical respite facility. So this is one of our newer programs. We did purchase this property a few months ago, which is very exciting. So as you can see, we operate this program out of an old motel building. It has 39 total rooms. Right now we have around 14 to 15 rooms. We did secure funding to help us purchase the property and renovate all rooms. So within the next few years, all 39 rooms should be up and running. So the purpose of this program, the focus is really on patients experiencing homelessness that are about to discharge from a local hospital. So it's very hard to recover on the streets. Hospitals are not supposed to discharge patients until they're fully recovered. We know that due to other circumstances, whether it be that a patient hasn't received the treatment that they need, or leaving against medical advice, plethora of reasons, it ends up happening. So instead of discharging to the streets, hospitals will get in touch with us, with our medical team, to see if they're a good fit for the care house, if there's any availability. So each patient is given a independent room They are seen by our medical providers as needed throughout the week. They are seen by our physical therapist, psychiatrist. If they need to be seen at one of our other clinics, or if they have hospital follow-ups, we'll help facilitate that. And they'll meet with our case management team at the care house to help make sure that they're not discharging back to the streets. And we have been very successful in that. We are maintaining a 50% success rate at not having patients go back to the streets after discharging. So whether that be finding them housing or reconnecting them with family in town or outside of town, we help facilitate that. And as one of our growing programs here in the next few years, we will hopefully have all of the rooms up and running. And then we have the Beehive. So the Beehive is one of our main stationary clinics. We are here at this building. It's on 7th and Paseo near downtown in the northeast neighborhood. So it's a really cool building. The ground floor is Nourish KC's community kitchen with the Prospect KC. So they serve free meals Monday through Friday for anyone that is in need of a free meal. And then the second floor is where we hold our clinics. Clinics run from 11 to 4. Half of the upstairs building is the medical side, and then the other half is our social support side, where we will have community partners come in and offer services. We have our staff case management team here. We have some community health workers integrated within our program. We have dentists, psychologists, and now we do have a computer lab, which is really the big update that we wanted to share with you guys. So we do have a computer lab, and we want to give a huge thanks to G Fiber. They provided the funding for this space, and we're very excited to integrate this into the Beehive and into our program. I'm going to let Kevin give us I'll run through a few pictures and then I'll let Kevin speak. So here are some more pictures of the computer lab. Okay, all right. Well, as you guys were able to see in the pictures, we have 6 individual spaces for our participants to be able to, access laptops and stuff like that. So we'll be holding about 30-minute seminars to be able to show people how to set up emails, get passwords and stuff like that, how to, navigate the web in a safe way. How to be able to recognize if a website is unsafe, that type of thing. Also, we will offer other services like printing. Obviously, it would have to be run by somebody and then be approved. But yeah, we just want to give the participants a safe space and just make it accessible for them to access anything that they might need in a digital manner. And just for them to feel comfortable in this space. So we do have a few goals that we have set for the computer lab. So Kevin came on board last week, was his first week. So this is his second full week with us. So we're still kind of we're still fleshing out what all the digital lab is going to entail. For now, we have these 4 goals. So we want to enhance our patients' digital health literacy. So like Kevin was saying, we're going to try to help those that come through have the ability to look for their health information. So the focus of our organization is healthcare. So whether that is, like point number 2 says, accessing medical records and telehealth. So we currently do not offer telehealth. All of our clinics are held on a walk-in basis. Patients struggle with maintaining scheduled appointments, so we've removed that barrier for them. However, a lot of our patients do have medical coverage or are seen at different clinics for different reasons. So if there is a clinic that they are being seen at that offers telehealth, and they don't have a way to get to that clinic, that would be a really good option for them. historically, what our case management team has done is also helping patients navigate their benefits and other social resources. We have one case manager at the Beehive, and they are typically pretty slammed, as you can imagine. So if the digital lab and Kevin can kind of help lessen that burden on them, then the case managers can focus on helping other patients, and then Kevin can focus on helping patients navigate those things. The other big thing is the continuity of care for our organization. So we are very lucky to have a very robust electronic health record system that all staff and volunteers can access regardless of what clinic they're working. So then we are hoping that the computer lab can give the patients kind of a fixed digital home base. So they've learned to trust us. They trust us a lot of times with their birth certificates or IDs, keeping those safe for them. So then if they can come here, they know exactly where that is. They can actually maintain a digital copy of that if needed. They know how to access that. They can have all of that within their own Google Drive or similar, so that they always have access and they know how to get that. So we wanted to just thank you guys for having us. If anyone wants to come tour the Beehive or work with us, or if your organizations are doing something similar, let us know so that we don't duplicate efforts. If you guys have classes that are going on that we can refer patients to, we can work together in that way. Likewise, if you guys have, if there are people that you guys are serving that would benefit from something like this, please let us know. More than happy to help. And like we said, we're still in the early stages of the lab. So this is all subject to change, but we're very excited to have this capability and add this to the services that we provide. So if anyone has any questions or anything, let us know. Or
Thank you so much, Gustavo and Kevin. That was amazing. Congratulations to all of the wonderful developments in your organization, including the care house and the new computer lab and Kevin joining. This is really exciting sort of growth and development for something that I feel like most of us residents think is a huge need in the metro area. I have one sort of shameless plug, and then I'll get to John's question. But Kevin, I'd love to get you connected with our Digital Inclusion Learning Circle. It's a meetup of folks who are already teaching digital skills classes in the area, computer, phone, whatnot. So I'd love to get you involved in that group just to kind of see. It's intended for, folks who are currently teaching or people who are interested or getting involved. So I'd love to just get you plugged in because I can't speak to the expertise of the trainers, but they can. So I believe did you put your email in the chat already? I believe you did.
Yep.
I'll be reaching out to you.
Thank you.
But that's wonderful. Thank you for sharing. And I will take it over to John for his question.
Thanks, Leah. Congratulations to Care Beyond the Boulevard. I'm always impressed with what you guys have been able to accomplish and the extensiveness of services and so on. So really congratulations on the work that you're doing, and keep it up. It's definitely needed. I have just sort of an oddball question actually, and that is so many of the serving groups that I've worked with around Kansas City are challenged by the languages spoken by the people that they serve. And I was wondering, how much of a challenge is that for Care Beyond the Boulevard?
So I can speak to the last 2 years, which is kind of the time that I've been here at Care Beyond the Boulevard. Before I came on, from what I know, we weren't seeing too many Spanish speakers. After I came on, we hired a few other staff members that speak Spanish. We started putting our clinic information in Spanish, and we've seen that start to grow. Now we have Spanish speakers at almost every clinic. We did recently, we forgot to mention this in in the presentation, we did start a virtual remote interpreting service. So we've contracted with them. So we have seen patients that speak other languages. I don't think the word is out about our services quite yet in other languages that aren't Spanish. But when patients roll through, we do have access to certified remote interpreters, either through phone or through video remote interpreting. So whenever they come through, we will be able to help them.
That's great. Thank you.
Looks like Rachel has a question as well.
Yeah, Gustavo and Kevin, are hospitals doing discharge planning with you directly for some of the folks that might not have a place to recover? Like, are they sending people to you directly, or is that for the individual to coordinate?
No, so the way the care house referrals work, we do ask it will happen that a patient will reach out to us directly. We do ask them to have someone on the hospital staff reach out to us. So we have a care house referral line that's shared between the two nurse practitioners on staff. So then they reach out to them, and the nurse practitioners will then coordinate with either one of them or one of our nurses to go and do an evaluation at the hospital. Let the patient know directly the rules and kind of what the care house looks like, what it's there for, to make sure that everyone is on the same page. So yeah, they do work with us directly, the hospitals do, to make sure that the patients aren't being discharged back to the streets. Unfortunately, with the limited amount of rooms, we're not able to accept everyone. There are also patients that have medical complexities that are a little above the scope of the care house. So we're not always able to accept every patient, but for the most part, we try to accommodate as many people as possible.
I also love how you said that there's a 50% success rate in getting them housing after that as well. That's really exciting.
Yeah, so so that 50% number we do like to share is not that half of everyone that rolls through is housed, but they're not discharged back to the streets. A lot of times patients want to go back to the streets. They're staying at an encampment with family or friends, and they're not in a position where they want to look for housing yet. So if that's what they want to do, we help accommodate that and make sure that once they're back at their encampment, they're going to be safe, and letting them know that they can still come and see us at our other clinics if they need follow-up care. We do also have patients that come through that are of that mind that they don't want to be housed, but once they're there, they realize, oh, like this is what being inside is like. They've been on the streets for years. So they have some sort of trauma, and they're hesitant to be housed or accept help. So then just kind of building that trust with them and then getting them somewhere, or they decide they want to go to transitional housing or seek stay at a rehab program, something like that, as long as it's not going back to the streets. And then even if we're not the ones that end their spell of homelessness, someone down the line can help them get housed.
Thank you for clarifying. Appreciate that. It looks like Raquel has a question.
Thank you, like everyone, for what you guys do. This is a hard population to work with, so I appreciate so much of what you guys do. When we shut down the Welcome Wellness Clinic, we have boxes of gloves. Would you guys take donations?
I can ask if you want to email me, or Kevin will forward that to
Okay.
either our program director who oversees all of the donations that roll through, or someone on the medical side.
Okay.
We usually do need a lot of gloves, but I'll just double check with them.
Gloves, yeah. Good. I will email you. And again, thank you. I live here in the Northeast area, so I am super appreciative of everything you guys are doing.
All right. Thank you so much, Gustavo and Kevin, for presenting. This was a great meeting. There's lots of new information, lots of great developments, and things to keep us excited and motivated in 2026. And it looks like, yeah, Rachel just shouted out, Raquel, if you didn't know, Leslie's side hustle called Reuseful, they have that website where you can go on and kind of just say, hey, I have this to donate, and it'll pop up tons of partners to donate to as well. So that is, I'll plug the website there to make Leslie happy. Okay, all right, let's get into our last 10 minutes. Just to talk about any community announcements that folks have in the area. I know I'm just going to say that our next meetings for the coalition will be February 6th on, I believe you can see this, February 6th from 10:30 to noon, and February 20th. There will be some good presenting going on. And I also wanted to just point out that KC Digital Drive, we have our newsletter that just came out. There's tons of great events that are coming up. Their A-Steam Village is putting on a summit this weekend. The Vernon Center in KCK is talking about their device launch for free devices for folks that qualify in Kansas. As John said, his health innovation team is coming up. There is a computer repair event with Briscolas right here at the LAMP campus, which is in Midtown, Casey Mo. And Net Inclusion, Leslie and I and Aaron will be going to Net Inclusion. It's a digital inclusion annual conference hosted by National Digital Inclusion Alliance. We'll be going the first week of February, and more sort of meetings to come.
Leah,
Yes, Leslie.
that's what I raised my hand to let everybody know about. I have a 50% off discount
Oh,
code.
yes.
If anybody was wavering because of the cost, I do have that. I think they've let the hotel block go, but honestly, we're staying at a nearby hotel that's much cheaper anyway, so you could probably find one that's close enough to walk to, just bundle up in the Chicago winter. But I'm happy to send that to you. Just email me and I'll get it right out.
That's great. And for anyone who's not already subscribed to our email list and our newsletter, please do that. I'll post the link in the chat. Does anyone else have any other community announcements, things coming up? Nobody? Raquel, you're not putting on any sort of welcome events or anything, are you?
No, I wish, but no.
That is okay. All right. Well, we will leave it at that. If anyone wants to stay on for any other announcements, please feel free. But otherwise, I will let you all go. Have a great MLK Day weekend, everyone. And we'll see you at the next coalition meeting. Thanks, everyone.
Great weekend.